Hey there, this is Dr. Evan Osar with Fitness Education Seminars. Welcome to this edition of Fitness Insider, where we'll continue our tutorial on fascia and fitness. If you missed part 1, check it out before following up with this one. From last time, we found out fascia is ubiquitous, meaning it's everywhere and it invests itself in all our structures, making an integrated system between neurovascular, myofascial, the ligamentous and joint capsules, even investing itself into the viscera of the abdominal and pelvic regions. Fascia contracts. It has contractile properties, and it functions as a proprioceptive organ. So therefore, it's important, and maybe one of the most important structures in providing feedback to the central nervous system about the position of the body. And as we'll see later on in this tutorial, what happens when the fascia is disrupted and the impact it has on posture and movement. Fascia can be affected and is affected by soft tissue and joint-specific techniques. So myofascial release, neuromuscular release, joint-specific techniques like joint manipulation, chiropractic adjustments, all affect the fascial system. So they can have dramatic effects on fascia and how our body functions. And again, if you don't do soft tissue techniques, foam rolling, sticks, balls, and even breathing dramatically affects fascia and the nervous system. So today we'll continue our look at fascia and how it functions. In the image to the left, you'll see the John Hancock Tower here in Chicago. The unique thing about this building is that the architects designed it using 30% less steel. So these cross beams, those X beams that you see going up the building, allowed the developers to make this building with 1/3 less steel without giving up any of its structural integrity. Similarly, our body has these cross linkages in the body that creates these X-type frames, like the anterior oblique chain, as you can see here in the right image, where the rhomboids, serratus anterior, external oblique, abdominal fascia, and contralateral internal oblique are all fascially bound together. So it allows the body to have incredible stability and incredible ranges of motion at the same time without having to have a lot of muscle bulk in order to create both strength, stability, and range of motion. In this image that's coming out of my upcoming book, The Integrated Movement Solution to Common Hip and Shoulder Dysfunction, you can see the cross abdominal fascia across the anterior aspect of the thoracolpelvic canister, and you can sort of get an appreciation of how cross-layered and cross-hatched these fascial structures are in the abdominal wall. And this is going to be an important thing to consider when we start to look at what goes wrong with our clients and why surgery and trauma to the abdominal wall can have such a dramatic effect on our client's posture and function. This image is right out of Strolling Under the Skin. A resource I highly recommend is a DVD that takes a look underneath the skin at the fascial structures and exactly what it's doing and how it's moving. So pick up the DVD, and there's a couple free videos on YouTube if you don't have the DVD already, and check out exactly how fascia moves, because that appreciation will give you an understanding or a better appreciation of what the heck goes wrong with fascia when it's not functioning properly. So take a look at this model, this hand gripper. So you see the arrows, so just pretend for a second that this hand gripper is actually our thoracolpelvic canister. We're looking down from it from the top. When the fascia and myofascial structures are functioning properly, we have a nice pull, even pull throughout the abdominal cavity and throughout our canister. So this is what it looks like when it's within normal limits. But when we have fascial binding and scar tissue, we start to get a pull in the direction of a scar tissue. And you can see the dramatic effect it has on this hand gripper just from pulling on one angle. It has an effect almost to the posterior aspect of the hand gripper. This is exactly what happens in our clients that have abdominal scars. Here's a patient of ours who had a C-section about 4 or 5 years ago. She developed scar tissue that strangulated her intestines, in fact, so badly that she had to have a piece of her intestines removed. We recently had 2 additional patients who said their parents or their mothers had to have very similar surgeries. They didn't have to have pieces of their intestines removed, but they had fascial scar tissue that bound up their intestines and created constipation and digestive disorders. So they were able to catch it before there was any internal damage done. But again, the one patient had a C-section, one patient's mother, another patient's mother actually had a hysterectomy, and this is what caused the intestinal binding from the scar tissue from these surgeries. So if you think, is this really that common? It probably is common in most of our clients, if not all our clients, that are having abdominal surgery. So the number one fascial issue we have with surgery is the formation of scar tissue, and this occurs anywhere in the body and everywhere in the body. We're going to focus on mostly the abdominal and pelvic regions. So what happens during scar tissue formation? Well, first, there's connective tissue irregularity. It becomes denser and more irregular, so again, it doesn't become normal tissue. The borders of the epimysium, the outer lining of the fascial, and the inner lining of the fascia becomes obliterated. So then the fascial lines aren't so well defined anymore. So what does this do to our fascial function? Well, we get the decrease in fascial sliding, meaning the different layers of fascia that are surrounding our tissues don't slide as effectively, and we start to get a pull towards the scar tissue. So why do we get fascial dysfunction? As we mentioned, surgery will definitely do it, as will acute trauma, as like an ankle sprain, for example, repetitive injury, as in runners who get IT band syndrome, that's basically a fascial dysfunction, and inflammation from dietary causes. But again, let's talk a little bit more about surgery, because all surgeries, including but not limited to C-sections, hysterectomy, gallbladders, appendix, ovarian cysts, D&Cs, gastrointestinal, stomach, and organ transplants, all affect the abdominal and visceral fascia. And nearly every patient that I have that has had abdominal surgery has abdominal breathing, abdominal wall dysfunction, and postural dysfunction. And I would go so far as to say that most clients that have had surgery probably have the similar dysfunction, even though they may not manifest right away from these surgeries. So this is my client again that had the abdominal surgery. You see the vertical scar. She also has a horizontal scar where they did the C-section. And you can see the postural distortion. Her head is sheared to the right. Her shoulder is lower on the right side, the direction of the pull and where they took out the intestines. And you can see her pelvis is higher on the right side. Everything's caving down on the right side. And this actually is an improvement from what she actually presented with. And she's had chronic back pain, and we've been able to help her by doing myofascial release and teaching her how to use the thoracolpelvic region again. So again, this is a more classic example of one of our clients, and you can see also what the prolonged effects of dysfunctional fascial lines are. This gentleman did not have surgery, but you can see how the forward head and forward shoulder and increased thoracolumbar extension and the abdominal distension and stiffness of the rib cage, all a direct effect of the prolonged pull of these fascial lines. So just as a recap here, fascia forms neuromyofascial chains, and when trauma affects these fascial chains, it alters the pull on the fascial structures and the structures that the fascia attaches to. And these lines of pull affect function, both our postural, static postural function, as well as what happens when the client moves, overloading certain areas of the body, underloading and underutilizing other areas. So what we need to do as fitness professionals is both recognize the signs of the dysfunction, find out if our clients are experiencing these issues, what surgeries and or traumas, broken bones, acute and repetitive traumas they may have, but definitely what kinds of surgeries they've had, so that we have a better strategy to help them improve. So coming in part 3, what are we going to do about all these issues that we found? So now we have identified why many of our clients have issues. What are we going to do about it? So I'm going to share with you in part 3 of Fashion Fitness specific strategies to improve function in your clients' fascial systems. Whether they've had surgery, if they haven't had surgery, if they just have postural dysfunctions from prolonged pulls of these fascial chains, I'll give you some strategies to specifically help your fascial system and their fascial system. So this is Dr. Evan Osar. Hope you enjoyed this short and brief look at why fascia goes dysfunctional. Like I said, in part 3, we're going to look at what to do about the dysfunction. If you like this, feel free to share it with your friends and or colleagues, and I'll catch you next time in part 3 of Fashion and Fitness. Have a great day.